Great, thank you, Lisa. Good morning, everyone. I'm Malika Lamont, and I'm a director for Vocal Washington, and I'm the lead Washington State Technical Assistance Team, and I'm one of the founding part of the founding group for the Olympia Butte Clinic and the director of harm reduction there here in Olympia, Washington. Katie, want to introduce yourself?
Yeah, hi, I'm Katie Strozik, and I'm the opioid response coordinator at Thurston County Public Health and Social Services.
And we just want to welcome everybody today to Transforming Our Communities. We're happy that you are all here, and we look forward to this collective opportunity for us to learn from each other.
So we're going to start it off with a land acknowledgement today. So I would like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial.
Please join us in expressing our deepest respect and gratitude for our indigenous neighbors.
Good morning. I think Tim was going to do this. I don't know if he's been able to log on yet. It looks like he probably is having to update his Zoom as well. So Caleb, would you mind walking us through this? And you're muted if you're talking, Caleb.
Sure, happy to. So our goal is really to increase understanding and gain insight, develop and support effective, compassionate relationships and care. And although I said that quickly, I encourage people to really try to kind of absorb that. I think the idea around compassionate relationships and care is really at the core of what we are going to be talking about the next couple of days. So I encourage people to kind of sit with that a bit. And we really invite you over these next couple of days to commit to being welcoming, really invite other folks to share, open-minded, encourage dialogue and listen. Even dialogue can be difficult in this format. Listening can also be difficult in terms of paying attention. So I encourage people to do that as well and really focus. That's a note to myself, by the way. And also to be kind, both in tone and words that are respectful, really a person-first approach. People are not their diseases, trying to avoid stigmatizing language, and at the same time trying to be generous and assume good intent. Respectfully inquire if appropriate. If you have a concern about language that feels stigmatizing, raise it and express why, and hopefully engage in some dialogue around that. And then be accountable to ourselves and others. And so for all of us, I hope we'll do that. And myself as one of the folks who will be doing some presenting and facilitating as well, I will do my best to really try to follow this. So thank you. And I look forward to a great day.
Thank you, Caleb. So just quick housekeeping slide. As you saw from the notification, we're recording this webinar and it will be posted on our Transforming Our Communities webpage at ADAI, the UW Addictions, Drug and Alcohol Institute. And when you joined, you were muted. Please stay muted so that we don't have background noise and your cameras can be on or off. When we start having presentations, perhaps turning all cameras off except for people who are presenting and then turning them back on when we have some interaction. Feel free to communicate with the speakers and attendees using the chat. And then later on today, we're going to be using breakout rooms for smaller groups so we can engage in some discussion and dialogue about things that we're going to hear this morning. And we will be taking breaks throughout the morning. Thank you so much to Vice Chairwoman Lonnie Greninger, who is going to welcome us. Lonnie is an Indigenous leader with the Jamestown Tribe, Jamestown S'Klallam Tribe. Lonnie, if you would like to unmute yourself and we can stop sharing if you want to be on camera.
Sure, yes, that'd be great. All right, I can see everyone's faces, or at least your little squares with your names on them. Well, thank you so much, Lisa, and to the team who has put this conference together. I raise my hands in so much gratitude. Mansen Uhatning is how we say it in my native language. So my name is Lonnie Greninger. I'm the Vice Chairwoman of the Jamestown S'Klallam Tribe. And for those who may not be familiar with where we're located, we are located on the beautiful Olympic Peninsula in Sequim, Washington. And so it's such a privilege to be able to be here with all of you this morning. I unfortunately am not able to stay for all of this today, and I wish I could. So now I'm going to be keeping an eye on this event for the future. And I see this is the 3rd annual conference, and I think that's just awesome. It's amazing. And I see here, just some really good key phrases, transforming communities, sharing innovations, reducing harms. And I just see this lining up with so much of my tribe's cultural values. We transform our communities through knowledge, spiritual knowledge, physical knowledge, emotional knowledge, mental knowledge, and we take this knowledge and we push it forward to those 7 generations, right? That everything we do today matters, that it's a good burden to have. Everything today, all the decisions we make, all the knowledge that we acquire, that we should push it forward to all of our communities and our children and our children's children, so that nothing is lost, nothing is broken. The cycle of healing, the cycle of knowledge, the cycle of sacredness continues on and on and on. And one of the earlier speakers this morning, having an open mind, I think when transforming our communities, I think about that too, transforming and evolving our minds to be able to resolve healing, to find healing, and, having us all come together, be open-minded, sharing that sacred knowledge with one another. That's how we're going to learn about one another. And that's how we're going to, increase everything that we have, from our spirits to our knowledge, our heart work, our compassion, our wisdom. We can't do it alone. And so I'm just so grateful for what you're going to be doing here and all of this amazing work. I'm grateful for engagement, especially on Zoom. I know that the virtual platform is not always the most ideal, and we want to be together. We want to be in person and face to face. But what I love about spiritual work, which I do consider this as part of our spiritual work, it can transcend the types of platforms that we're working in. So I know that good work is still going to come through, that good work is still going to be moving our spirits, moving our hearts, and moving our minds while we're in this platform today. And so I want to start us off in a good way here as my concluding comments. And I just want to offer a prayer over us in Nushkayamutsan, asking the great Creator to come over us and to bless this particular conference and all of the good work that is here today. So Ma Si Chichai Si Siam, Ma Si Chichai Si Siam, Creator, you are great and we lift your name. We thank you for the sun, Creator, that gives us sunlight, gives us all the beautiful light that we need to be able to wake up and walk with a good step on this earth as we do our work. We thank you for this beautiful earth, Creator, that gives us all the wonderful natural resources that we need to sustain ourselves and to be able to help sustain others. Creator, I am so thankful for the beautiful friends and relatives that are gathered around this virtual table today. Would you bless our minds? Would you bless our hearts? Would you bless our mouths as we speak with boldness and with compassion? Creator, we are grateful and we lift your name. Amen. Thank you, everyone. And I appreciate you. I appreciate all the work that you're doing, not only for your own families, yourselves, your communities, but for those of you who also touch Indian country as well. I raise my hands to you. Hatnings.
Thank you so much, Vice Chairwoman Greninger. That was a wonderful blessing, and I love your energy as well, and I hope we can continue that throughout the day. I'll share with you this planning committee here. There are many of us, but I really want to give them all credit, and I should say that the energy you just heard is what the energy of these meetings has been like. They're just wonderful energy, good challenging conversations, really to bring you, hopefully these next couple of days, a really meaningful meeting. My name is Caleb Banter Green. I am a researcher at the UW Addictions, Drug and Alcohol Institute. You've already seen my dear colleague, Lisa Ray Thomas, who has really helped organize and put on this whole event and coordinate all of us, many, many, many feral cats. And And then I want to mention my colleague Meg Bruner here at the ADAI, Nicole Branch here at ADAI. This is her last week with us. Thank you so much, Nicole. It's been wonderful working with her, working with you. We've learned a lot. We've laughed a lot. So thank you. I want to thank Kayla Moontree from the Kitsap Public Health District, Patricia Dean, who is our contract manager and brings great energy and support for our work from the Healthcare Authority, Malika Lamont, who you've already seen from the Olympia Butte Clinic and the Public Defenders Association, my longtime friend and colleague Brad Feingood with Public Health Seattle and King County, Katie Strozik with Thurston County Public Health, Victor Mendez, Family Health Centers in OMAC, who you may recognize from previous meetings, Noah Fay from DESC, supportive housing, other types of housing support programs, Paul Lakoski with the Purchase Project in Tacoma, Chelsea Amato from Tacoma Pierce County Health Department, Aviva Rubin from Carolyn Downs and Country Dot Clinics, Michelle Sandoval for Foundation for Youth Resiliency and Engagement, Tim Candela with the State Department of Health, Deontay Damper with Vocal Washington, Tressa Pfeiffer with CMAR Community Health Centers, Wendy Stevens with American Indian Health Commission, Theo Oliphant Wells with Public Health Seattle King County, Alexi Orr also with Fire, Lori Fleming, Community Health Improvement Plan Behavioral Health Consortium, Catherine Akia, American Indian Health Commission, Mark Cook, ACLU of Washington, and John Marie Award, American Indian Health Commission, Kevin Schutte, Mason County Commissioner, District 2, and Kristen Prentice, CMAR Community Health Centers. Yes, it took a village to put this on. It's a really wonderful process. It's taken months to sort of think about what would be meaningful information and to share with you and appropriate processes to share that information with you. So I really want to very much thank the planning committee for all of their work.
So before I pass it over to Malika to kind of kick us off for why we're here today and what we've done over the last 2 years of this conference, I wanted to give us a chance to kind of view who's in the room today. I know it's really hard on Zoom, so I'm hoping that if everyone can type in the chat and introduce themselves with their name, organization, if you're with an organization or agency today, your role at your organization, and then anything else you'd like to share about yourself in the chat as well. And then there should be a poll popping up on Zoom with questions for you to fill in about what types of different categories and roles you're in today while you attend. I know Nicole is gonna pop that up. So keep in mind, it is multiple choice, but you can pick more than one. So just trying to get a view of who's with us today, feel free to click as many options that are applicable to you. See a lot of people starting to introduce themselves in the chat, so thank you for that. Then from here, I kind of want to kick it over to Malika to give a brief overview of how transforming our communities was started and what really spurred our efforts here.
Thank you, Katie. Transforming our communities was truly born out of community. Katie and one of our friends and colleagues, Maida Hogan, and we were at a local watering hole in Olympia, Washington, brainstorming about what it would be like if we could put together a group or a collective opportunity for people to learn from each other and to uplift the good work that's happening around our state. I think we all know that oftentimes things happening in Seattle, people hear about that, but we don't get to hear about the really good work that's happening in other places across the state. And as a person who's made Thurston County my home, and as well as Katie, that, you know, there's a lot of good work that's happening, and we wanted to create an opportunity to uplift that, and also to share have expertise sharing from both directions. And so that is how transforming our communities came together. Initially, the idea of it. And then, you know, unlikely pairings. Caleb and I have worked on projects for many years, as Katie has with him as well, through, you know, harm reduction work, as well as for graduate school work. And it was through those connections and what many would consider an unlikely pairing that the opportunity to make transforming our communities a real thing. That is where that happened. And so we were able to develop this platform. We started it in 2020. We're going to talk more about, what that looked like. Transforming our communities. We wanted in 2020, we focused on health, equity, and justice for people who use drugs. We had about 200 participants, and we, kept the same format that we have had today, where we make sure that we acknowledge our Indigenous neighbors, and we talked about how the war on drugs has impacted BIPOC people. We made sure that we wanted to center this around the lived and living experience of people in our communities. And then we also had, we did the surveying like we're doing now. And we also discussed the SSP survey process. That's something that I think a lot of people around the state maybe don't completely have a grasp of, like, what that looks like. So we were able to share that expertise. And then we continued with, in 2020, talking about the continuum of housing supports and services, and like what that would look like if we actually had a continuum, and not just sober housing, but places for people to live all the way across the, the spectrum. And then we had our regional breakout groups. In 2021, our theme was supporting people who use drugs, and we had almost 180 participants. And we, of course, stayed focused on our format of, lived and living experience narratives. And there was also an opportunity to introduce the Council of Expert Advisors on Drug Use and the Research Expert Advisors on Drug Use. And that's a project of Vocal Washington with Seattle King County Public Health. And you're going to hear more from the person that, Thea Wells, who created that, process, and then we work in collaboration with her. And then we really did a focus on data from a local, regional, and statewide trends, and what do we need to learn, and who do we need to talk to? And then we looked at harm reduction approaches for serving people who use meth and other stimulants, the role of housing and housing support services for people who use drugs, transformation and innovations for improving how we serve people who use drugs, reducing stigma, increasing compassion, youth, young adults, and fentanyl. And then we closed it out, and we've kept our connections. And here we are again this year. So we just really look forward to joining in community with you, sharing knowledge with you, with each other, and moving forward to help transform our communities.
I really want to emphasize too that the conference was built around uplifting the voices of folks with lived and living experience. And I know the Zoom poll popped up and then went back down for most folks. But if you were able to look at it before it popped down, over a quarter of the folks in the room today identify with having lived or living experience. Thank you, Nicole, for popping that back up. You can see that over a quarter of folks have lived or living experience, which is so important because, like Malika said, we really noticed that focusing on folks with lived experience has been a gap in a lot of the conferences and gatherings that we've had, and being able to center that for these 2 days is extremely important for us. So from here, I want to turn it over to Lisa Ray Thomas to give us kind of an overview of our agenda.
Thank you, Katie, and thank you to everyone who has introduced themselves in the chat and responded to the poll. And before I go over the agenda, I'm going to give a quick summary of the responses to the poll. Thank you for running that poll for us, Nicole, and for everybody that participated. It looks like 75% of you participated, which is awesome. So as Katie said, we have 26% of people with living experience with us today. 7% said they might be someone, or there's someone who might be accessing or wanting to access services. 31% are behavioral health, primary care, etc. providers. 29% care manager, navigator, peer support. 41% harm reduction services provider. 3% tribal, urban, Indian. 18% criminal legal. 2% first responders. 12% doing housing and homeless services, and 29% other. And we can look at the other in the chat later. So here's the agenda for today. And we will be taking breaks at various times. So we had the welcome and introductions already. We heard from Alika and Katie about why we're even doing these gatherings every year. We're going to take a break and then hear from people with lived living experiences who are sharing their narratives and expertise with us to ground our thinking and our work together today in the voices and lives and expertise of people with lived and living experience. Then we're going to hear from Caleb, highlights from the 2021 Syringe Services Program survey. We'll have a break and then come back together for a panel, Justice by Geography, Implications of State v. Blake, or SB 5476, with a panel including Mark Cook, Everett Maroon, Commissioner Kevin Schuette, and Thea Oliphant Wells. So we're really excited about that. Then we'll take another break and then go into breakout rooms by these 3 different topic areas so we can have smaller group discussions. We'll have a couple questions for you and then come back together and share what we talked about in our smaller groups, introduce what we're going to do tomorrow in the morning, and then close at 11:30 and then close the formal part of the day at 11:30 and leave the Zoom room open for unstructured and informal networking, because that was a request we've had every year. It's just an opportunity for people to stay in the Zoom room and talk with each other.
I want to turn it over to Caleb Bantagreen now to share some background and information from our 2021 Syringe Services Survey.
Awesome. Thank you, Katie. I'm really glad we started excuse me, I'm glad we started with that so you can really see the people we're talking about. I'm about to show you data, which can feel like an abstraction. So I'm really glad we grounded it in people first. If you would bring up the slides.
Caleb, were you going to share your own slides today?
Oh, I can do that.
Okay.
Actually, do you have them sitting there? Or otherwise, I can go grab them.
Yes, I have them. Hold on one sec.
Okay, thanks. So
while Megan's finding those slides, I just want to thank Christina again for her beautiful comments, and do feel free to continue your showing your appreciation in the chat, and we will share them with the participants who shared their stories with us. So thank you. Sorry, Caleb.
No, thank you. It's a really perfect setup, and I really appreciate the grounding in some people's experiences. So I'm going to share with you results from the last fall's Washington State Syringe Service Program survey of clients, which is a large effort of a lot of folks. I'm going to talk about survey methods and the setting overview, the demographics, substance use. I'm going to talk particularly about some things you just heard about around smoking patterns and interest in safer smoking supply. Talk a bit more around opioids and stimulants, and around some issues around access to care, and then have a bit of a discussion at the end just about sort of some of the so what. I think you just heard the so what, but I want to show you some of the data around that as well. So first, just an enormous thank you to the Syringe Exchange staff and volunteers for the time and effort to make this survey happen. Generally, let alone during COVID, just incredible effort. And really, most importantly, I want to thank all the clients, participants who trusted us with their personal information during this survey. And it's interesting, what I hear from folks is that clients are willing and excited to do this surveying to help support the organization that supports them. So while it is work, it is something that people are really willingly doing and excited to contribute to. So the surveys developed by us along with Public Health Seattle King County. This work comes out of work that Public Health Seattle King County has done for a decade prior to our beginning this work. And syringe service programs provide input on topics and questions. And we've been doing this statewide every other year since 2015. And then we started doing some qualitative work in between years. And I just want to show you really quickly a nice webpage that Allison Newman put together. What's important about these surveys is that they really tell a story together. And so I want people to know that these are all now in one place. You can see each of the surveys on our webpage. There's these 4 different years, and then a summary of what's new or what the special topics were, how many folks were surveyed, and links out to the survey for each of those different years. And then we also are including the information on the qualitative surveys as well, which provide very important context. The intent around those qualitative interviews is to sort of explore in more depth something that came up in a previous survey, and or to help us start figuring out what the next round of questions should be. And who are these programs? And you'll hear me lapse into the term syringe exchange. I've just been doing this for a long time, and that was the vernacular 27 years ago. The reason we talk about syringe services programs is that they are services and they do a robust set of things. And increasingly, they're also doing other types of services, including smoking supplies, as you heard. So really diverse organizations that provide harm reduction services to people who use drugs. There are different types of entities: public health, nonprofits, treatment agencies. Some are in fixed locations, some are mobile, some are a mix of the two. And the services are really quite diverse. Obviously, syringe exchange itself, safer injection equipment, naloxone and overdose education, HIV and HCV testing, referrals to SUD treatment, housing, and medical care. And increasingly, over the last couple of years, a lot more on-site low barrier access to buprenorphine, which is one of the medications for opiate use disorder. And so you can learn more about syringe services programs on this webpage that DOH hosts. And so why do we do this work? We really want to learn about and from people who inject drugs. And in my thinking around this, by sharing and discussing these data, we can create shared understanding and meaning to drive action. This isn't just data for the sake of data at all. This is all about creating informed action and really impacting our communities in a positive way. We want to help support public health programs through partnership and collaborative data collection. As I said, really improve services and supports for people who use and or inject drugs or use them in other ways increasingly in Washington State. So just briefly around methods, you can look at this in detail online. It's an anonymous survey. We try to get everyone. Can't always get everyone. They're busy or may not want to participate, but we try to involve everybody whenever possible, both in terms of clients being willing and also having staff and volunteers have time, because often exchange can get really busy. Participants receive candy as a thank you. This is usually done a quick verbal survey by staff or volunteers. Most of these folks, the data is collected on paper and sometimes also on a RedCap online data entry tool. And we also, very importantly, I can't express this enough, the syringe service programs are given back their own results of their data. In fact, they're given back the raw data. And we report on our webpage the statewide summary. We don't report local data. Those data are owned by the local programs, and they're the experts. So when people come to us and want to know what's going on in Walla Walla or Port Angeles or Ellensburg, we say, please contact the folks who actually know these data the best, and they can choose how and whether to share these data with you. So just some demographics quickly. So this last round of the survey, we were able to involve 955 people. That's down a little bit from the 1,100 to 1,300 compared to previous years, but that's amazing generally, let alone during COVID. We had responses from 20 counties and 21 organizations. This does not include every entity. It doesn't include one of the largest syringe service programs. It does some of its own surveying, but this does generally cover 80–85% of the syringes that are distributed. So it's a substantial majority, but it's definitely not everyone. And then what this shows here in terms of color coding, where these dots are, is they're the zip code that people reported sleeping in the night before. So this is really important because it shows where people are coming from and sort of the spread and reach of these programs across the state. And just to remind people in terms of population, our state is about 80% of the population's on the west side of the state and 20% in the eastern side. So we're really appreciative of everyone's efforts across all of these communities. Age, our mean age, our average age is 40, median age is 38. But when you look at this distribution, you'll see just a huge range and really large numbers of people across the age span. In terms of gender, 58% identified as a man, 40% as a woman, a little less than 1% as non-binary, a little less than 1% as a trans man or trans woman. For race and ethnicity, people were able to indicate multiple race ethnicities. Caucasian white was the most common, 10% American Indian Alaska Native, which is a large proportion relative to the state, 7% Latino Hispanic, 5% Black African American, and you can see some smaller proportions of other race ethnicities. So a little bit on demographics. Housing status, 39% indicated they were homeless, 28% unstably or temporarily housed, 33% permanent. That's pretty similar to the last 3 cycles as well. 92% were insured, the vast majority on Medicaid. 25% had been in jail or prison in the last year. That's a pretty substantial decrease compared to previous years, which makes sense both in the context of COVID, as well as the Blake Supreme Court decision around possession cases in February of last year. And about half had used the emergency room in the last year. So that's a very high proportion compared to the total population. Substance use. Let me explain this slide a bit. So we're looking at 2 different things. We're looking at substances used in the past 3 months. So in this first column, any use at all in the past 3 months, 86% said they've used methamphetamine, 69% heroin by itself, almost half a goofball, heroin and methamphetamine together, fentanyl by itself mixed in, or by itself or mixed in with something. And then you can see other substances, alcohol, benzodiazepines, opiate medications, powder cocaine, crack cocaine, and speedballs. So that's any use. Those who said a drug was their main drug, and that's however they conceive of main drug, that could be frequency, that could be identity, that could be social group, however they self-identify that. 29% said methamphetamine by itself was their main drug. 41% said heroin by itself. 21% said methamphetamine, which appears to be a bit, methamphetamine and heroin together. A goofball, that appears to be a bit of an increase in terms of goofball. And then really new is 3% of folks saying fentanyl was their main drug. And this now, I have to say, this is last fall, and all signs are that that 3% is much larger than that now. You just heard those stories just a few minutes ago. So these data now are already starting to feel a bit dated. And I know I've been doing drug epidemiology for over 20 years. I've never seen the drug market change so quickly. It's just dramatic. We used to see things in multi-year shifts, and now we're seeing shifts within the market, even the shifts within the fentanyl market on the order of weeks to months. So things are changing very quickly. Another way to look at this is, let me get that off my screen. Another way to look at this is when folks have used substances. So this kind of yellowish line is past 3 months use. Blue line is past week. The green line is 5 to 7 days in the past week. That's essentially daily or near daily use. And given the very long duration of some of these substances, methamphetamine in particular, using 5 days a week may really mean that a person is essentially has methamphetamine in their system every day. So you can see for methamphetamine by itself, about half of folks have used it near daily. Same for heroin. About a quarter of folks have used goofballs on a near daily basis. And then what's interesting is that though fentanyl, only 3% said it was their main drug, 14% said they used it on a near daily basis. And then you can see some of these other substances, less common, but still happening as well. So let me slow down and pause on this one. This is a new slide. This is a new question that was asked. And I'm really proud of our team for really thinking about how to dig into this. And let me explain it a bit. So the last time you used fentanyl, was it on purpose? So that's over here on the left side. 266 said yes, 133 said no. That's 2/3 of people said they used fentanyl on purpose. I want to be really clear that on purpose doesn't necessarily mean they wanted to, but it means they use it on purpose. For many folks we're hearing who have historically used heroin, they cannot access heroin anymore. So on purpose isn't necessarily the same as wanting to. It's just sort of, they were using it on purpose. They had a need right then to use, and they chose to use fentanyl in that moment. What did the fentanyl look like? So among those who said they used it on purpose, this is last fall, 2/3 said in a pill form, a quarter said a powder form. Small proportion said patch, that is a pharmaceutical product, I should be clear. Neither a pill nor a powder is a pharmaceutical product. So these pills are all bogus pills. These are stamped M30s, blue or green pills, tablets, and 9% said mixed in with other drugs. I was surprised last fall at the relatively large proportion that reported using it in a powder form. We had just started to hear about that much in the 6 months prior to that. That's continuing to evolve. We think that powder form is often in the context of folks who have historically used heroin, who are shifting, not necessarily willingly, but because they need to using fentanyl, often using it in a powder form, which might be easier to inject, although we're also hearing about folks smoking. In terms of folks who said they didn't use it on purpose, the vast majority of time, it was mixed in with other drugs. So there's a lot more to unpack on that, but I want to at least start that conversation there. So a little bit more around smoking. This is the route of ingestion of drugs in the past 3 months. So let me break this one down as well. Goofball, this combination of heroin and methamphetamine. Injection only was 61%. I want to be clear, this is in the context of a syringe exchange survey. This proportion is likely quite different among those who are not participants at syringe exchange, a lower proportion. Smoking and injecting, sort of changing what route they use depending on the context and the time and what's available, is 35%. Very few said they smoke it only. My point being is the context of where the survey was done, we're going to see a smaller proportion who smoke only. In the total population, I would expect or guess it's a larger proportion. Fentanyl, quite surprising to me, honestly. 48% said they smoked it only, even in the context of predominantly injecting some other drug. Heroin is really a mix of injection only, smoke and inject. And we see some smoking only. Again, we would expect that to be a larger proportion in a different venue. And then methamphetamine, small proportion inject only, most commonly smoke and inject, and a proportion of smoking only. I also want to point out the smoking of other substances. 83% smoked or vaped tobacco, and half smoked, vaped, or dabbed cannabis. So these are not the only substances that people are smoking. So when we're talking about safer smoking supplies, this is in a context of folks who are often smoking other things as well. Interest in smoking supplies, we asked folks, would you like to get free clean pipes or foil to smoke opioids, cocaine, or meth among those who had injected? 23% said no, and I want to slow down on that and say 23% said no. It isn't that we don't need safer injection equipment and supplies and services, we do. So I want to emphasize that. 23% of folks said no. 72% of folks said yes, 2% said they already get them. Among those who said yes, do you think folks would, if you had access, would you inject less often? 2/3 said yes. And then there is some research out there that is observational that shows when smoking supplies are available, people often will inject less. And you heard that as well in some of the stories previously. This is another aspect I want to emphasize, peer networks of people who do not inject. How many people do you know right now who smoke opioids or stimulants but don't inject them? So we're at a syringe exchange, we're asking folks, how many people do you know who smoke but don't inject? Essentially people who predominantly don't have a reason to come in right now. And 91% of folks said they knew other people, an average of 11 other people. And I think this is very important as we think about what opportunities are present within the context of syringe exchanges to do additional services, to reach additional people, either relying on peers to connect with other folks and supporting them in doing that, or offering additional harm reduction services on site that would bring more people in because we have our messengers in terms of folks who are already trust this service that we offer and perhaps could bring their other friends in if we had something to offer them as well. Overdose, unfortunately far too common. Have you had an overdose in the last 12 months among those who used opioids? 24% said yes. About half of them had one overdose, and the remainder had 2 or more overdoses. This is looking at whether folks use fentanyl or not. If you used fentanyl, 27% reported an overdose, which was significantly more than the proportion who had used primarily heroin. 20% reported an overdose. We're going to be doing some more research on this, but this already shows a significantly higher risk of overdose for fentanyl, which other recent research shows as well, and also just makes sense. I should just say that the substance is much higher potency, much higher risk for overdose, and it's used much more frequently. So you have a drug that is inherently biologically a higher risk for overdose, and it's getting used many more times. The number of opportunities for overdose is that much higher as well. Have you witnessed an opioid overdose? 61% of people had witnessed an overdose. Half of them, 3 or more overdoses had been witnessed. And again, you heard that in those stories as well. A gentleman had gotten naloxone, I think, given it to his nephew, and it was used within 24 hours. Acute consequences of methamphetamine use. In the past 3 months, have you felt like you were losing your mind, manic, or psychotic while on meth? That is serious psychological effects. A third, 30% said they had. About 19% felt like they'd had a heart attack, stroke, or seizure while on meth. And overall, 12% of people who had used meth had been to the ED in the past little while around these symptoms. So some emergency department utilization is being reported as well. And we have a colleague right now on this meeting who is doing his master's thesis, which he's going to complete this week on this exact topic. So we'll have some more information to share with folks soon on this point. And then just a couple of things I just want to wrap up. Substance use patterns among participants have changed. There's clearly an increased use of methamphetamine and fentanyl. There's an increase in drug smoking. These programs are essential services for people who use drugs and are really a part of the continuum of care for substance use disorder. That is, we can be using increasingly these locations and services and relationships to offer other services, to offer healthcare, to offer substance use disorder services, treatment services for those who are interested, to offer counseling and other supports, and just, most importantly, to continue to offer harm reduction and engagement and connection with folks who are using drugs. They're well positioned to expand these services, and there are rapid changes happening, and no one knows more what's happening on the street than folks who are using and folks who are volunteering and working at syringe service programs. And really, just critically, you've heard it. I'm not in a position to make these decisions. I'm not the expert. Programs and policymakers should include people who use drugs in their decision making, not just in their information gathering, but actually in their decision making about what services should be offered, what things should be prioritized, what things should be funded. So with that, just to keep us on time, I want to take a quick break. I know there were some things in the chat. I'll try to respond to those during the break. Let's just take like a 3-minute break. There'll be another break in an hour, and we'll come back at 10 o'clock to continue everything. So thank you, and we'll see you all in like 3 minutes.
Thank you, Caleb. And I noted in the chat that we will have the opportunity to ask questions about Caleb's presentation, the lived and living experience narratives, and the upcoming Blake panel during the breakout session. So you will have an opportunity to share your thoughts and ask questions there too. See you in a couple minutes.
We're going to be moving back. We're going to be moving into our next session, which is Justice by Geography. And we're going to be exploring some of the implications of the State v. Blake, or SB 5476 decision, as well as looking at all politics are local and policy and legislation informed by people with lived and living experience. Our panelists are going to be Mark Cook from the ACLU, and Everett Maroon from Blue Mountain Heart to Heart in Walla Walla, Washington, and Commissioner Kevin Schutte from Mason County, and Thea Oliphant Wells from Seattle King County Public Health. They're going to be talking to us about the implications of where you are in the state and how policy rolls out, and the role of people with lived and living experience, and how we can work together to transform our communities to create an equitable process.
Thank you so much, Malika, and apologies, everybody. I'm trying to pull up my PowerPoint slides, and they are not popping up here on Zoom. Hang on, let me try this one more time. Well,
It's not a Zoom meeting without that, right?
yeah, it's so strange. PowerPoint usually pops up here. Let me scroll down. There it is. Sorry, user error. Okay, are you seeing that?
Yes, it's not in presenter mode yet. There you go.
Okay, sorry about the user error there. Good morning, everybody. My name is Mark Cook, he, him pronouns. I'm with the ACLU of Washington, where I work on a variety of policy issues, including drug policy and behavioral health. Just want to say thank you so much for having me, and to the organizers and to everybody who is here to talk about these really important issues, because it's really a period of change, I think, right now that we're all experiencing, both politically, just in terms of what you heard from Caleb and people with lived experience. There's just so much change going on. So I'm honored to kick off this segment of the conference, and I was sort of tasked with really just kind of doing a recap of some of the big legal changes from the last couple of years, because there's been a lot of changes. So this is really a very, very quick overview of really complicated issues that frankly we could be talking about many of these things for days. So it's really just a quick orientation. The notion that this is justice by geography, just wanted to mention, is there's the state law, right? Or there's local laws that are technically on the books. But the reality is it's what the local environment is that matters more often. So, we have one set of criminal laws in Washington state. The truth is we have probably at least 39 different criminal justice systems because it's so different by county and by city. So that's where this notion of justice by geography comes from, is that it really depends what's on the ground. So wanted to start with the Blake decision, which I'm guessing most of you are familiar with, but as a reminder, this was a Washington State Supreme Court decision from last February, which found Washington's primary drug possession statute unconstitutional and voided it entirely. So there was a period of time last year where Washington had no criminal possession law on the books. And that has now changed again because the legislature in 2021 passed a bill, Senate Bill 5476, which recriminalized it and did a variety of other things. Just on Blake, I wanted to also mention that there is a lot of work being done by allies, many who are probably on this call, to try to get people relief that had past drug possession convictions, to try to get people's criminal records cleared from those cases, and to also give them their money back, for fines and fees. So I will also note, I assume these slides will be shared, and there are links within this PowerPoint that kind of give you more information. So the big bill that passed last April, I guess April 2021, 5476, did a variety of things. Criminal legal changes, it made changes to behavioral health services, it did appropriations for those services, and then it tried to address State v. Blake implementation issues. This is the current state of the law at the state level for drug possession, and it basically recriminalized it, unfortunately, in my opinion, down to a misdemeanor. It was a felony, now it's a misdemeanor. And before somebody could be charged with that crime, law enforcement has to offer a referral to assessment and services at least twice. So what I've heard, the data will show this eventually, I think, is that drug law enforcement for possession really has decreased significantly since the Blake decision. But it may just be a matter of time if law enforcement chooses to use those diversions and then to start charging people again. Also of note is that the criminal law changes in that bill from last year have a sunset clause in them, which means that if the legislature or voters don't take action before July 2023, so next summer, the law would actually revert back to the post-Blake pre-5476 law. So if that were to occur, we would primarily go back to a decriminalization legal landscape. Other parts of the bill were to really try to create a robust service alternative to the criminal justice system. So this is the Recovery Navigator programs, which are modeled off the LEAD program, created here in Seattle-King County. And these are to be implemented via the Healthcare Authority and Behavioral Health Administrative Service organizations. And this is supposed to be the type of service that people could be diverted to instead of being arrested and booked into jail. That is a big endeavor and things are still being worked out, but that was in the law. The law also included training for law enforcement on substance use disorders. People at UW and ADAI have been leading on some of that work, and then other kind of various criminal changes that needed to be made for things like sentencing grids. There were bigger changes to paraphernalia laws as well. So one thing that the bill did is it actually decriminalized, kind of possession of most paraphernalia outright. One notable thing is that this section of the bill doesn't have an expiration or a sunset clause in it. So this is kind of the law of the land until, it were changed again, but there's no sunset clause for this. Also need to point out, though, that the civil infraction for giving, paraphernalia out still exists. So this is one of the issues that has come up in the smoking supplies context, in that this law has a carve out for injection syringe equipment, but not smoking equipment. I think there are good public health arguments that smoking supply distribution is permitted under things like the Brockett decision and public health authority. But it's definitely true that there is some kind of confusion about the legality of safer smoking supply distribution, although I would argue that there is a very strong case to be made that it is lawful. There is also a lot of work underway from this bill to create this public health alternative in addition to the Recovery Navigator program via an advisory committee called the Substance Use Recovery Services Advisory Committee, or SURSAC. There is a link to that, and this is being overseen by the State Healthcare Authority. And it is tasked with a variety of things in terms of what the current landscape is for services, what we should be doing differently, really addressing all sorts of issues that I think people on this call care about. And if there's one specific call to action, I would say pay attention to SURSAC. Get involved. It meets monthly. There are subcommittees. All the meetings are public. There's an opportunity to do public comment. Please be paying attention to that work because it's really important for the people that we care about. Last slide here for me, just kind of drug policy moving forward. I already mentioned that there is a sunset clause for most of the criminal law changes in the bill. There's also a proposed ballot initiative that is currently collecting signatures, Initiative 1922, which would actually do full decriminalization and provide significant amounts of funding to services. It's not clear yet whether this initiative is going to move forward and be on the ballot. If it does go on the ballot and it is passed by voters, I think that will sort of answer the question on the criminal law side of this issue for a while. But if not, it'll go back to the legislature in 2023 in terms of what Washington's approach is going to be for substance use disorder and the criminalization of it or not. So that was a lightning round. I'm sorry to go so quick. Here is my email if there's any questions I can answer after this, but wanted to be quick to get to the other presenters. And thank you so much for having me. And I don't know, Everett or Kevin, if you were going to go next.
I think Everett and then Kevin and then Thea. Thank you so much. And go ahead, if you have questions or comments, put them in the chat and we'll watch for those. Thank you.
I was just going to talk a little bit about how things look locally here in Southeast Washington. My name is Everett Maroon. I'm the executive director of Blue Mountain Heart to Heart. We're a 501c3 nonprofit. We've got syringe service program sites in Kennewick, in Walla Walla, and in Clarkston on the Idaho border. We also run 2 low barrier Suboxone programs, one in Kennewick, one in Walla Walla, and then we also handle an MAT program in the Walla Walla County Jail. We're engaged in the Recovery Navigator program, and we are arrest and jail alternative contractors, a subrecipient to comprehensive health care. So the joke out here is if you're using drugs in Walla Walla County, you're going to run into Everett. But the good news is I'm going to try and help. So, we did see a very big shift with that Blake decision last year. And Mark, as you were talking, I was thinking, holy cannoli, that was only a year ago, February. It feels like it was 5 years ago to me. And the very first thing that we did out here was to run over to our jail and bring them Narcan, because we know that release from jail is a real driver of overdose and overdose death, and that tolerance effect getting interrupted is a big deal for driving people to respiratory arrest. So that was sort of our first step. Everything that you saw earlier from Caleb's presentation, I want to echo here. We see a lot of folks moving into using fentanyl. As Mark has said, there are reasons to think that fentanyl, or that smoking kits or safer smoking kits are perfectly legal in Washington state. Certainly seems like it's a gray area for some, but we have worked with our local law enforcement to kind of, not engage in trying to cite people for paraphernalia if they're picking up a safer smoking kit from us, and we've asked them not to cite us for a civil penalty. And so far, that is holding. So I'm happy about that. Part of my concern as a harm reductionist was that at the same time we see much more potent, volatile, drugs on the underground drug market coming into contact with our participants. We're not seeing participants come in as much to our SSP until we started giving out safer smoking supplies to them, because as Caleb alluded to earlier, there wasn't as much motivation for them to come in. I have noticed just through my own work that the idea of an overdose is an abstraction to people until they witness one or experience one. So it's kind of hard to motivate people to come into a syringe program to get naloxone when they don't feel like there's sort of this very big pressing need on them. So if we can pull them in with smoking supplies, then we have more opportunities to provide them with naloxone kits and education. So that's worked relatively well for us. I'll also say kind of generally, I see a difference in participants across my 3 sites. Where there are more resources, people are doing better. Even if they're, there's not necessarily, we could talk about this all day too, I guess, without getting into trying to surmise that there are correlations between service infrastructure robustness and how participants are doing. There does seem to be some sort of relationship that we observe through our work. So even though the Tri-Cities is a huge population center, they actually have fewer resources for people than we do in Walla Walla. And so it's harder to serve the participants in the Tri-Cities because they have a harder time making it in to see us at all. Mobile services, I think, are really important as a strategy out here in rural parts of Washington and geographically isolated areas. We know that if we can see people more often and we can engage them more deeply, then we can maybe provide some services to them to help them kind of avoid jail and incarceration and trips to the emergency department. So I'm a big believer in trying to bring as many services into the SSP service matrix as possible. Co-locating a nurse has been a big help for us, doing a wound care clinic, doing vaccinations for folks, not just HIV and hepatitis C testing, but being able to bring some treatment to people, PrEP prescribing, as much as we can bring for people, because we are working so hard on that trust relationship with individuals that sometimes they'll say yes to receiving a service from us where they might not be, talking to another medical provider for things. So that's just kind of an overview. I'm very concerned about overdose for folks. We're definitely seeing people we're working with overdose more often. We're definitely seeing people in our Suboxone program relapse more often and then try again. So I'm happy to take any questions about any of that, and also happy to turn it over to Kevin.
Thank you. I think we'll do questions at the end after Thea.
Hello, my name is Thea Oliphant Wells, and I work for Public Health Seattle King County as the Harm Reduction Program Manager. More importantly, I have a lot of lived experience with chronic homelessness, injection drug use, and other things that lend my expertise to my work. And part of my work is facilitating the CDU project on the public health side. Oh, is Kevin here?
He is.
Okay. Does he want to go now, or should I just keep rolling?
Keep going. I'll
Okay.
jump in after you.
Great.
That's all good.
Deontay Damper is also going to join me for talking about CDO and Redo wherever he's at, as someone who's worked on both projects. So CDO is the Council of Expert Advisors on Drug Use. How do I move? This is our logo. We pronounce it CDO, but it's CEADU. And really the thought came, we were inspired by Vancouver, of course, because they're harm reduction leaders in North America, Vancouver, BC. And they have a collab project there. And we got inspired to maybe try and do something local and really bringing together people who use drugs and honoring their expertise and asking for their advice on how to best support them and serve them in the community, what policy changes would benefit them, what program needs they have that aren't being addressed. And so it's a really fun project. We get to do a lot of community engagement. We also have the research arm, which we call Redo, which is research with expert advisors on drug use. And some of our UW research partners applied for some grants to get some money to do some research that engages people with lived and living experience as experts. And so it's a really fun project to get to work on. I get to spend a lot of time in community. For me personally, I wasn't really able to share my expertise on my own experience until I had several years of recovery and a master's degree. And so we really want to make sure that we're not creaming the lived experience bunch and just engaging with people who, have been able to move beyond their circumstances. We want to talk to folks who are living that life right now. And making sure that we're finding out what's going on now in the community. I can advise on injection drug use from my experience, but it's been a long time. I don't know what it's like to smoke fentanyl pills, et cetera. And so it's really important that I am not the expert in the room, that I just help to facilitate the experts. One of which is Deontay Damper, thankfully, and he can talk a little bit about his experience with the projects as well.
Hi, everyone. Hope everyone is having an amazing day. I've been loving all the presentations today. My name is Deontay Damper. My pronouns are he, him, his, and I do also work with project management in the areas of CDO. Being a part of this project, or being a part of this community, I will say, because sometimes we look at things as projects, but really as community. Coming out of the pandemic, a really different transition, I will even just say, for all community members, let alone for myself as a person who uses drugs, let alone going through the stages of trying to find these new conversations about methamphetamine in our communities. It's no longer the war on drugs. And then the thing in my community, Black people, my community people don't think Black people use methamphetamine. And then also, we're still not having the conversations about LGBTQIA community members in that. So when I look at CDO, it gives us an opportunity to start delivering a compass to our community members with helping one another guide each other through our path. And I mean, at the end of the day, I would say that it's been life-changing, not just working within CDO, but within Vocal, because coming out of this pandemic, all of us that are all on this line are all a part of that compass with guiding our community members. And CDO is getting right there in the thick of it and letting people know that we are not leading to walk in front of you, we are walking alongside each other. And I think that that's pretty much the gist of what I have. I have a really big soapbox that I can jump on, y'all, but y'all don't want that today. I'll see y'all more so tomorrow, but I'll leave it there and give the rest to Kevin.
Great. Well, thank you so much. This is it's been really great to be able to listen in today and to join this conversation. And so I'm just really grateful to Lisa for the invitation and having an opportunity to work with Thea and Mark and Everett and Deontay to hear from you today as well, and putting this panel together. I want to start with kind of how I center myself in this policy work. as a county commissioner, as a local elected official. A lot of my interest and passion for this work starts many years ago when I was about 3 or 4 years old. One of my earliest childhood memories was of my dad, who was a pharmacist, who was an alcoholic and began to take pills from the pharmacy that he worked at, narcotic painkillers. And one of my earliest childhood memories was my dad leaving to go to court-appointed rehab. And throughout my dad's recovery and some of the times that he struggled with his recovery, I was just always reminded of how recovery isn't linear, that there's not one clear, direct path for folks that are in recovery. And so how I center my work, and this is something that has stuck with me for many years. And you know, when I think about politics and policy development, so often the people that we work with in government and our constituents are looking for a very cut and dry, black and white, linear solution to the problems that they face in their world. And that's just not the case with recovery and how we approach you know, this important work. And so I don't have a relationship with my dad today, and I can't every day think about fixing just that relationship. And so I'm really blessed and grateful to have an opportunity to work on system change. And as a local county commissioner that has a public health department under my purview, I'm able to go to work every day with some really dedicated and talented professionals who work in this space and who have a lot of professional and lived experience that help inform my thinking as a policymaker. Our work in Mason County has been going on for a long time, but coming into local government, we had a community forum in 2016 that really served as a jumping off point for our programs as we know them here in Mason County today. And it clearly stated what our community was going through. It clearly stated what our community needed to do. And I think challenged in a lot of ways the thinking of a lot of people in our community who were uncomfortable with some of the concepts around harm reduction and all of the work that's involved with that. And so this community forum was put together by in part by our public health department. And so I know you heard a little bit earlier from Christina Muller-Shin, who's a fantastic team member with us here at Mason County Public Health, but also Dave Wyndham, Lydia Buchheit, who's now retired from our public health department, and our county health officer, Dr. Diana Yu. We're just really critical in helping get that work started and bringing on board Abe Gardner, who some of you may know through your work is just a tremendous leader here in our community, and beginning to build out programming that, like I said, challenged some of our conventional thinking in Mason County, a rural county here in Western Washington. And so as they were thinking about, you know, how do we get a law enforcement assisted diversion program on board? How do we do a syringe exchange program here in Mason County? How do we go after grants and other funding sources to supplement our treatment sales tax, our 0.1% treatment sales tax? You know, they were able to come to us with ideas and asked us to trust them and their experience and expertise in these fields. And you know, my job as a county commissioner is to, you know, to evaluate policies through two lenses. One is to absolutely listen to my constituents, listen to what my community is saying, but also to view and judge policy and programming through my own experiences and my own sort of understanding of the situation as it is. And so that's why I started today with the anecdote about some of my early childhood memories of having a parent going through you know, their own struggle with addiction and recovery and that whole process for them, and being able to view that with some empathy, but also some hope that if we lean into this work, we can get good things done for our community, that we see people who, you know, are maybe a little bit different than us, that are struggling in this way, that we're able to still see their inherent dignity and value and their many contributions to our community. And so that centers our work. And so, you know, when we look at the programming that we offer here in the county, there's this sort of three-pronged test to kind of determine whether or not this is something we're going to pursue or continue to work on. And first off, is what we're proposing and planning technically correct? You know, is there evidence? Is this based on evidence? Is there other research that shows that this is an effective or promising path to take? And so we rely on subject matter experts, many of which you know, you are on this call today. Do we have the organizational capacity to implement that program? What do we need to do to staff up and scale up so that we have the right people in place to effectively run that program, to reach people where they are and help them along on their journey? And then finally, and this is where I think a lot of areas, this is where a lot of local jurisdictions tend to struggle, and this is where you really run into community conflict, is there enough political support in order to pursue a particular program or a policy? And so, you know, we have really spent a lot of time thinking through, you know, the different programs that we offer and how we go about presenting those to the community. And, you know, and we're not always the loudest community in terms of talking about the programming that we have. We don't always, and this is because we have a really talented and humble staff. They're not looking to do this work and when there are successes, get the pat on the back, because they know that, you know, that work has to begin again the next day and the day after and so on and so forth. And so rallying that political support is the time, it takes time and it takes effort and energy, and it takes honest and open conversations, sometimes with people that don't agree with you. And, you know, and so whenever we were, I'll use LEAD as an example in our community. There were a lot of conversations that happened before we applied for the initial round of LEAD funding a couple of years ago through the state, you know, and that's bringing in not just folks that, you know, that are in public health, but that's also having difficult conversations with law enforcement or the business community. You know, sometimes, you know, they want to see, you know, like I said, a very linear, very black and white, you know, response to some of these challenges that they're seeing. And so pulling them in and having those uncomfortable conversations, you know, in private settings where it's a little bit more comfortable, where, you know, we can all kind of be free to work through any kind of conflict has been really helpful here. But I also know that, you know, when it comes to making a policy decision, we do have to embrace some of that risk and some of that discomfort that comes along with it and try things. When you see folks in your community that are suffering, families that are suffering, you know, certainly there's an obligation on my side to take those risks and trust the people that work in this field in order to get results for our community. And so over the past few years, we've had some really good champions in public health. We've had some really good champions for this work in the broader community. And I think about Chief Bo Bakken, who's a fire chief in our community from North Mason Regional Fire Authority. And you know, he has just really spearheaded this work for us outside of public health, and holds a bi-monthly stakeholder group that pulls together a variety of stakeholders, both in the public sector and the private sector, from a variety of backgrounds. And is that roundtable discussion, is that networking opportunity, you know, that we're able to go through, that to bring in new thinking, to bring in other resources, and to, you know, really hopefully make a difference, even if that is just for one person. This work is absolutely worth it. And so I'm really excited to see where our programs head from here. We've had some new staff come into our public health department. There are some new funding opportunities at the state level. And so I think, you know, being able to continue to embrace this work view it through that lens of organizational capacity, technical correctness, and building that political support, I think we can build a lasting system that hopefully 4-year-old Kevin can be proud of, and that he can see some hope there for other families where they need it. Thank you. Just happy to answer questions when that time comes up as well.
Thank you to all of our panelists. I just feel so honored to be able to be here with all of you today. I know all of you. Anyway, and y'all are such great people in your communities and just in general. Sorry, I just got to gush a little bit. Anyway, okay, so if we have any questions from the audience today, from the group, if people would like to ask any questions, we have about 20 minutes to do that in.
Malika, actually, we're going to break at 10:40, come back together at 10:50. So we have a little bit of time. And as we mentioned earlier, when we come back together, we'll be getting into smaller groups. So definitely an opportunity to join this group and ask questions and make comments. Sorry for the confusion.
Correcting me. No, that's great. Thanks.
There's so much in the community that is going on right now as far as people's emotions and feelings and vitriol, but also like lots of pockets of support for programs. And from an elected official, do you have advice or thoughts to us in the community about what we can do to help steer and engage the conversation to make it more productive, to provide help and support to people who are struggling with their drug use from a policy standpoint, I guess?
Yeah, that's a great question, Brad. I appreciate that. I think two things come to my mind right off the bat. One, boy, are we not living in a time where we need to take the temperature down on everything. I think looking at all of the pandemic related issues and how that really laid bare, I think, for everyone to see, whether they want to acknowledge it or not, some of the issues that you all have been working on for a long time, and that at the policy level, we at the county level, but also at the state level, have really struggled to kind of figure out what makes sense, what doesn't, what works, what doesn't. I think one of the things that I find to be really helpful is, just trying to, really figure out who are we trying to serve, who are we trying to help here, what problem are we trying to solve. And I think by putting that work at the center of our conversations, we're able to kind of get above some of that noise, that's so persistent in our politics today. And I find that there's really a big disconnect between what's happening at the local level, whether it be a county or a city or a nonprofit, and what's happening at the state level. And so I know I'm going to speak for not just myself and my county, but for all county elected officials in the state, where we really feel like the state legislature needs to work more closely with us to develop policy that is actually effective and implementable in communities. And I spent some time working in Olympia at the legislature as staff prior to coming to the county level. And Olympia is really, I think they do a really great job of thinking they got it right before they come to local people who are on the ground doing the work to figure it out. And so I think whenever you have an opportunity to pull your legislative delegation into these conversations, even if they're one-on-one, sidebar, offline type conversations, build those relationships, and then work to kind of turn down the heat, because some of these conversations can be difficult and controversial.
Thanks, Kevin.
Okay, I think we're going to take a 5-minute break, y'all, and then we're going to come back and go into the panel. So feel free to save your questions.
I wanted to hop in here really quick. We Jason had put a comment and raised their hand, and we didn't call on them. So that but I wanted to make sure that they got a opportunity to speak.
Hi, can you hear me?
Yes, yes.
I don't know if this is the appropriate place. This is the first one of these that I've sat through completely. And I had posed the question both to my council people and to my state representatives and to people at the Addiction Institute. And I come from the user community. I have been a crystal meth user for this time around for like 10 years. I'm queer. I live in a low income housing building. And the question I had posed that I don't know how to get the answer to was I've had 4 friends of mine enter into like state run or state funded, I assume, like rehab facilities, and none of them make it through. They make it like a week. And so I'm curious to know like what the success rates are of what I call Recovery Incorporated, what the success rates are for people who actually, you know, talk about diverting them into these programs, but are the programs even effective? Because from where I'm sitting, they're not effective. And some of the things that are happening in these facilities seem to really geared to help people fail. And these were people who like entered voluntarily, who really wanted to get clean, and they didn't make it a week. And so I'm wondering if those numbers or those statistics are available. How much are the state taxpayers paying for failed recovery programs?
I don't have the answer to your question, but I do think, you know, most of the time we're blamed for like not being treatment ready, or you know, if we don't, you know, follow the plan, then it's something that we're doing rather than the program isn't meeting our needs or meeting us where we are. Yeah.
I think it's a question that needs to be asked, because if people like that already suffering like the worst sorts of harms are going into these programs and they're not able to make it a week and they want to get clean, then there's a fundamental systematic problem that means all of the talk about diverting, are you ready to get clean yet, blah 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 blah, is actually just noise. And that's concerning to me. And there are a lot of things obviously that are concerning to me. It's coming from the user queer community, like there not being a voice specifically from the queer community. Drugs are a queer issue. They've always been a queer issue. They will always be a queer issue. And we were pioneers once upon a time in that sort of thing, which we're not anymore. It sort of has just sort of disintegrated into it's just disintegrated. But it is concerning to me that there is so much emphasis, even from drug courts or whatever, putting people into rehabilitation services that don't work. And I think that's just a fundamental flaw that no one seems to be addressing. So, I mean, ideally, yeah, you know, manage your substance use so that you can have a better life. And I've been clean now for 2 months, but I was a good, kind, decent person before I got clean, you know, and it will be when I go, or if I go back. But I just, there's no hope to, I mean, once you've left on your own accord, like for, you know, then, and you've done that twice, that really takes hope away from people that there really is even a way to manage your life better and to avoid some of the harms that come from the people who just are the most marginalized by drug use. And so I just, I thought those numbers might exist, you guys might know that. Like how many people are just, how successful are these recovery programs? Like percentage-wise, it seems like that data should exist.
Jason, my son is gay and I will never give up on him. Never. I know that my boy has it in him and I'll never give up. That does not define him. I love that boy to the ends of the earth. And let me tell you, I'm the Mormonistly little Mormon mom you'll see out there. It doesn't matter. So if that doesn't.
No, I have a mom that's exactly the same way, you know, and I just went and saw my mom.
On a mission, and that's just fine. And his siblings love him, and that does not define him.
So
Jason, to have a mother that loves you is just like fantastic. I mean, it's like getting like the lottery. Like everyone deserves a mother who loves them unconditionally.
So I saw that Caleb also put in the chat, Jason, trying to connect you with the statewide treatment work group, because they're going to work on trying to redesign the system to be more successful. So if you want to connect with him in the chat, that would be great as well.
I appreciate that. Thank you.
Yeah, for the sake of time, we will skip our break. I hope Lisa is not internally screaming at me for saying that, and go ahead and move into our breakout rooms. So we'll have 3 breakout rooms in just a second. Nicole will go over the logistics of how to actually get into your breakout room. Our 3 breakout rooms focus on the presentations we had today. So we have one about lived and living experience narratives. We have the other about our syringe services survey. And then our third one focuses on the 3 presentations that we just had now. So you want to pick which breakout room you want to go into. You'll have a facilitator in your breakout room to kind of facilitate some questions and further conversation. And then we will all come back together as a group at 11:15 to kind of report back from our breakout groups and then move into the next part. So Nicole, do you want to let people know how to pick a breakout room?
Yeah, so the majority of folks will have gotten a pop-up on their screen listing the 3 breakout rooms. If you did not get a pop-up on your screen listing the 3 breakout rooms, on your panel at the bottom, there's a box you'll see on the slide here. There's a box that says breakout rooms. Click that. That should open the panel that has the 3 breakout rooms listed. And you will just click what room you want to enter, and it should move you right into that. If you are having any issues selecting what breakout room you'd like to go into, or if you are unable to select a breakout room, let me know. I can physically move you into the breakout room, but give it a shot first before reaching out.
Thank you, everybody, and thank you, Nicole. It looks like people are figuring it out.
Yeah, I see the numbers dwindling down, but again, if it's not working for you, let me know. If you want to move mid-session, you can click that breakout room button again and move into whatever session you like. Malika, what room would you like to be in?
Surprise me. It's okay. I just don't know how to make it work. Thanks.
Perfect.
Hey, everybody, if you're still in the main room and you missed this, we're going into smaller groups by the 3 topics so far this morning: lived and living experience narratives, the SSP survey summary, and justice by geography. A box should have popped up on your screen. If you scroll down or up, you can see the 3 groups with a button to join. Or you can go to the bottom of your Zoom screen where it says break.
I'm going to take that as we're ready to keep moving on. So I hope everyone enjoyed their breakout group where they were able to have a little bit more of a discussion. We want to report back now to our larger group since we didn't all get to attend each of the 3 sessions. So looking for the top 3 discussion points that came out of each breakout group, I will just call on them. So someone from the syringe services survey group, want to share the top 3 that came out of your group?
Yeah, I can report back on that. Hi, everybody. I'm Mandy Slidkey from Public Health Seattle, King County. I don't know if I have the authority to say the top 3 things, but I'll just pick out a few things that I guess I thought were interesting. And if other people from the group want to chime in, please do. But some of the things that people thought were interesting is that we've noticed that people have been happy to not be injecting with this kind of general shift from injecting heroin to smoking fentanyl. So people are happy to no longer be injecting, but then there's some downsides with having to increase their frequency of use. And along with that, because fentanyl is such a short-acting opioid, and then along with that short-acting opioid, we have, this combination of a rapid onset of the drug and a short duration that the drug lasts. And a lot of folks might know that increases addiction potential as well as overdose risk. So folks that are getting started with fentanyl, have some increased risks, not just around overdose, but also around addiction potential. And then, with that too, a lot of folks are, enjoy the feeling of fentanyl and wouldn't want to switch back to heroin if the drug supply were to change again. And needing to meet people where they're at, with harm reduction, safer supply around fentanyl, because people might not want to switch to buprenorphine or methadone or whatever for treatment, because it doesn't have that same feeling of rapid onset and short duration, of course. But if we want to reduce harm, which we have, people can use fentanyl without the same harms, and they do every day in the hospital. We would need a safer supply, sterile conditions, and all of these other things that keep people from getting infections and reducing overdose risk. I'm kind of rambling a little bit as I look at my notes, so I apologize. We talked a bit about stigma, of course, and how that weaves throughout all of this. And another important point, last thing, is that one of our participants commented about accessing healthcare, or accessing specifically care in the hospitals, and how she's seeing that that's changing, where people who are using are no longer coming in for things like abscesses, or coming in for abscesses less often, where they would tend to stay in the hospital longer and feel better throughout their treatment stay, because they're getting antibiotics and their wounds are healing. Where instead people are more often coming in for overdoses, where they don't stay as long, and it's a really sort of like quick in and out, and it's hard to engage people in that kind of environment. So if anybody wants to add anything, please do.
All right, how about from the policy group?
So that's the group Justice by Geography.
Yes, that one.
Thea, were you gonna report out for us?
Oh, sorry, I just got all sidetracked with Tim's link he put in the chat. Thank you. I feel like we had like one big thing and then some smaller items, but really the biggest thing was that stigma is guiding policy. The drug war is being reignited, and there's just a lot of scary directions that policies are going in that we know is just going to create more violence and harm to our communities. Some of the things that came up was like a lack of focus on root causes, like trauma, that we just talk about, you know, the drugs and the addiction, and we don't talk about why people use drugs, especially in good ways. Like sometimes people do drugs because they're fun, but it's always about what the drug problem, right? and a sense that like everything is connected. We can't just do one thing because we don't just have one problem. And so really everyone needing to work together and create, you know, the kinds of responses that our folks need.
Thanks, Thea.
Those were everything.
And then for the living experience one that we did off of the safer smoking, a couple of the things that we really focused on is the importance of letting folks self-identify, as well as using non-stigmatizing language. There's often a lot of folks without lived experience who throw around the term addict and things like that, and letting less stigmatizing language into our lives so that we can use that, but then also letting folks identify however they want when they do have that lived and living experience. And then emphasizing the importance of community and a robust caring network around folks. And then two other areas that we really focused on are the needs to compensate folks for their time and expertise, and really raising that up, and that it doesn't just mean gift cards for participation. It means compensating folks with money for their expertise and time, and not having the rebuttal of, well, what are people going to do with the money afterwards? Because we don't ask that of other groups. And then also looking at how to further other harm reduction efforts, such as distributing safe smoking supplies, and how to do that through evidence-based practices and using kind of financial numbers to show dollars saved and things of that aspect. And the fact that an effort of harm reduction is acknowledging that folks use drugs to enjoy them and that it's fun, which I know Thea touched on, Tim touched on it as a chat in the chat, and that is a huge part of harm reduction as well, is letting folks self-identify with that. From there, I will turn it over to Lisa to go over our day 2 agenda and the tracks that we have for tomorrow.
Wow, thank you so much, Katie. Malika, before I do that and we close, do you have any closing remarks?
I'm not sure if Malika is still on the line, but I think I will interject just in the space of being a part of Vocal Washington. Well, we are here. You know, in most cases, we are not asking for a seat at the table. We are building our own in this space of finding wellness within our communities. And this is just day 1. Day 2 will be filled with just as much. Please feel free to tune in tomorrow. Sorry, Malika didn't leave me with any notes, but at the end of the day, it's just, I can leave you with this quote. We can always say that we're going to be there, but as a group right now, we are making a more impact when we're actually showing up. We are showing up for one another. There's needs in all these, in different counties, in these rural counties, that some of us out here in King County and bigger counties can actually do a better job of advocating for. We have parents that are on the line, such as Miss Penny, that are still out here within the fight for her community people. We need more of this. This is exactly what this circle is for. Tomorrow, we will be continuing to protect and educate and build our community with more group discussions. And again, if you don't know who I am, I'm Deontay Damper. I am the project manager for Vocal Washington. Excuse me, I'm the community organizer for Vocal Washington and the project manager for CDU. And I'm very happy to be here with you all today and can't wait to see you all tomorrow. How was that for an ending, Everett? Was that okay?
Thank you, Deontay. And I don't know if you know this, but the photo that's on your screen is of
Malika.
Yeah.
Yes. I strive to be like her every day. Actually, I logged into her Zoom on accident this morning. So we'll be fixing that tomorrow.
Thank you, Deontay. So thank you all so much for a very powerful, compassionate, and interesting morning. We hope that you will join us tomorrow morning. We'll start off the day like we did today with a land acknowledgement and reminding people about the importance of compassionate language and interaction. We'll have a welcoming and a blessing from an Indigenous leader. And then we'll have the opportunity to participate in 3 different tracks. engaging and serving adolescents with a really amazing panel of people, distribution of safer smoking supplies to dig more into the work that's being done at the Tacoma Needle Exchange and allow for questions and discussion. And then the third is coalitions to impact, direct, and inform policy to better serve people who use drugs. And these tracks will run twice with a break in between, so you'll have the opportunity to join more than one. And then we'll come back together again. So once again, thank you so much for your time this morning, for all of your contributions, for all the work that you do. And if you want to respond to any of those questions, what have you learned today? What do you want to know more about? What is one thing you will take back to your day-to-day in the work you do? Anything else in the chat? Everybody is welcome to stay. We're going to leave the Zoom open until noon for unstructured and informal networking. And we will stop the recording for that section. So once again, thank you so much, everybody.